Forward and Out has been made possible by the generous support of the following. The Loft, Lesbian and Gay Community Services Center. ARC's AIDS-related community services. Stephanie's Living Room. Psychological Motivations. In the Life. The Coven Cafe. Carol Halbert, Licensed Associate Broker. Bars Club Cafe. The Color Group. Mary Elizabeth Edelman Photography.
It has been predicted that by the year 2000, cancer will surpass heart disease as the leading cause of death in the United States. More than half those deaths will be among women. Our guest on this edition of Forward and Out battles cancer every day. She's here to help educate us about those cancers which strike only women and why lesbians are at higher risk. I'm Sandra Gonzalez. Join me in welcoming Dr. Karen Bigman, hematologist and oncologist at the Norwalk Medical Group in Connecticut. Hi, it's nice. Thank you for being here with us today.
It's a pleasure. Thank you.
I want to start this by reading some stats to you, and I know we've had a conversation about this, but I think that these are fairly alarming statistics. There are approximately 250,000 cases reported each year of female-oriented cancers. 30% of women will develop some form of cancer in their lifetime, and that translates to roughly 1 in 3. Okay. Women between 40 and 70 are in a higher risk group, but over 50,000 cases have been reported recently of women between the ages of 20 and 40.
Right.
I find that one in particular to be the most frightening.
Basically what that just tells you is that this is no longer a disease of older people, as it used to be thought of, and that we are now seeing younger and younger women who have all different types of cancer. Not just women's cancers, but now men's cancers, or what were thought of as to be men's cancers years and years ago. Now,
actually, you mentioned men. Do women develop more cancers than men?
What's happening now is that men used to have cancers at higher rates of the lung, of the pancreas, and now those are now equalizing. Women and men are now having the same numbers of those same type of cancers. So really there's just an equalization rather than women getting more cancers. And the other fact is that women have more organs to get cancers in, unfortunately. We have gynecological organs which are very prone to cancer, which men don't have. Men have prostates, but we tend to have a lot more organs susceptible to cancer.
Okay. Now, what are the major female cancers? I mean, just for the benefit of our viewing audience.
I just briefly want to just mention lung cancer, and this is not just a female cancer, obviously, but this is actually now the #1 cancer in women. And this is one of the reasons now why women have cancer more than men do. But besides lung cancer, the major female cancers are breast, which is the most common cancer in women, but not the most common killer. Lung, again, is the most common killer in women. Ovarian, endometrial, and cervix.
Okay. Again, for the benefit of our viewing audience, which of these do you think takes more lives overall? I mean, there's been a lot of...
Well, clearly, breast cancer, out of the gynecologic malignancies, the ones that only women can get, breast cancer takes more lives.
It does.
Yeah.
It does. Well, for the purposes of this discussion, I would like to concentrate a bit on breast cancer, only because we've been hearing an awful lot about this recently. Finally. You say finally, I think you feel this is long in coming. Tell us a little bit about this most frightening statistic, women between the ages of 20 and 40. I mean, this was my mother's disease, my grandmother's disease. This could very possibly be my disease now.
Right. Well, in breast cancer in general, we're now finding that more women that are premenopausal are being diagnosed with breast cancer. And it tends to be a more aggressive type of cancer than is in postmenopausal women. They tend to need very aggressive therapy, which includes chemotherapy, radiation therapy, sometimes extensive surgeries, sometimes bone marrow transplants.
What do you think is triggering this in younger women now? Do you think that it's environmental? Do you think it's...
I think that there's a lot of factors involved here. I think that we're probably just picking up a lot more of it now because we're finally focusing on the breast. And women now are aware of breast cancer, and the medical community is more aware of breast cancer. So, you know, better screening is one part of it. But there are so many risk factors now that are involved.
Such as?
Environmental factors. And when I say environment, I'm really encompassing everything. I'm encompassing diet, I'm encompassing exercise, I'm encompassing radiation, and just basically everything that we're exposed to, whether we expose ourselves to it or whether somebody else is exposing us to it. But there's definitely environmental links between breast cancer and
younger women.
Younger women, yeah.
Right. Now you mentioned that there's premenopausal and there's postmenopausal breast
I think
cancer.
of these as two different cancers, actually. You have a higher risk of developing breast cancer once you're postmenopausal. But if you have premenopausal breast cancer, these are much more aggressive cancers. They're sometimes often difficult to detect because a lot of premenopausal women don't go in for screening because they don't think that they're at risk for anything.
Right.
And it's also difficult to sometimes detect this because they tend to have dense breasts, so mammograms may be difficult to read. It's hard to get 20 and 30-year-olds to do breast self-exams. It really is.
It's hard to get older women to do breast self-exams.
But there's a little bit of a state of denial when you're young that, you know, I'm fine, nothing's going to happen to me.
Well, I think that's a symptom of youth in general. I think they just don't tend to think that they will ever get sick or whatever.
But they really are two different cancers. And
is that to say that you also treat them differently?
They generally are treated differently. A lot of that has to do with the fact that the premenopausal breast cancers are more aggressive, and they really do need much more aggressive therapy. And it's actually been proven now that if you give premenopausal patients more aggressive therapy, they will do better.
Now, you mentioned something that I thought was fascinating before we got on camera. You said that sometimes a genetic tendency towards breast cancer, a younger woman could, if she knows this ahead of time.
Recently, and very recently, we have now identified an abnormal gene that will predispose certain women to breast cancer. And this is the whole idea behind gene therapy, which has been publicized greatly.
Both positively and negatively.
And negatively, correct. If you take women over the age of 30, probably only about 5% of all breast cancers are truly hereditary. But once you start to see young women with breast cancer, 22, 23, 24, 25 years old, probably over a quarter of them, this is truly hereditary, and this is truly some kind of abnormal gene that they either inherited or has somewhere along the line has mutated.
Right.
I try to look at breast cancer as a accumulation of risk factors. And although you may have a hereditary gene that may predispose you to breast cancer, something in the environment may trigger it.
Right, right.
So that's why not everybody with this abnormal gene may develop breast cancer, but it's certainly a way of predicting if they will, or being able to monitor them more closely.
Mm-hmm. Now, I mean, you said something that I thought was very provocative, that some of these women are opting to have what I think is the ultimate preventative measure. They are having
bilateral mastectomies.
Bilateral mastectomies.
Yeah. This is not done often, but I mean, in women who have very, very strong family histories of breast cancer, women who have a mother who has died of breast cancer and a sister or two sisters who have died of breast cancer, especially of early ages, a lot of these women are opting for prophylactic mastectomies because they have a very high risk of developing breast cancer.
So they're opting for this even before anything's been detected?
Correct, because often by the time it's detected, it's just too late.
Right.
And that's why their sisters and their mother died of it. It's because it's just too late. And it isn't that easy to pick up breast cancer all the time in young premenopausal women for reasons I mentioned earlier. You know, that their breasts are very dense.
Right.
So that mammograms cannot pick up subtle changes.
Mm-hmm.
And as I said before, the premenopausal cancers are aggressive, so that even if you have a very small tumor that's not picked up on mammogram, it can really spread like wildfire to the point where it's too late to really cure it.
I'd like to remind our audience that we're talking to Karen Bigman, and this is Forward and Out. I mean, my mind is reeling with all of these things that I'd like to ask you. I want to talk about mammograms specifically, but before we get onto that, this is again something we talked about beforehand. Women who have had implants done, or women who are considering breast reduction. One would think with breast reduction, because so much tissue is removed, that maybe the risk factors go down, but they really don't.
There's never been anything proven that if you take off tissue and you have less breast tissue, that you're going to not develop a malignancy.
Okay.
Smaller breasted women certainly don't have a lower incidence
That's something I wanted to ask
breast
you, yes.
cancer than larger women. The only thing is that it's easier to detect in smaller breast women, because when you do a breast self-exam or the doctor does an exam, the lumps are easier to feel, they'll pop out.
Right.
But unfortunately, by the time a lump is there, it's often,
so far along.
Pretty significant.
Right.
What we're trying to do now is detect it before that lump appears, or before there's any sign.
Now, women who have had implants should, I think, probably be even more vigilant, if you will, about this.
The only problem with implants is that sometimes it's difficult to detect a breast cancer. And that's really the problem with an implant. It depends on why the implant was done and what type of implant it was. There's been a lot of news about the silicone implants. People now are really mostly going for the saline implants. But if an implant was done for cosmetic reasons only, really the only thing a woman has to know is that she may be a little bit more difficult to detect her breast cancer, and that she just has to follow up. She has to just really go by the guidelines and not skip those mammograms yearly, depending on her age.
Now, the mammograms, I mean, we all know that they are relatively safe. And you also mentioned that there have been significant improvements, or maybe not significant, but there have been improvements in the technique, in both the technique and the results.
Right. There have been a lot of improvements in mammogram, and actually the qualities of mammograms are now getting much, much better. The radiation dose is very, very low, but we are now starting to really look into other ways to detect early breast cancers.
Such as?
Basically, a mammogram is just an X-ray. And again, young women have dense breasts. If you're fibrocystic, it may be difficult to tell if there's a subtle little change there. So we're looking now into things like ultrasound, which I use actually commonly if somebody has a lump, because the ultrasound will tell you if it's solid, that goes more for malignancy versus a cyst, because many women have cysts right before their periods. MRI is now being used as an investigative tool to detect early breast cancers. And we're now using even state-of-the-art types of mammograms where they're done by computers. You can get beautiful, beautiful images. They're called digital mammographies. Now, a lot of these are investigative and not available to the public, but I predict that within the next several years they will be.
That's encouraging.
Yeah.
Well, you mentioned something about women who are prone to cysts. Probably these women, again, should be certainly not lax about lumps in their breasts, just because they're prone to cysts this way.
I mean, fibrocystic breast disease is very, very common.
Right, exactly.
There really has been no proof that the majority of fibrocystic breast disease increases your risk of breast cancer. The problem is that if your breasts are always lumpy and bumpy, it's very, very difficult to tell what's a lump and what's a cyst.
Exactly, right.
And that's why breast self-exam by the woman every single month is so important, because she will know her own breasts, and when something's different, she will be the one to detect it. A doctor examining her breasts every year will never remember if this was there last year. And that's why it's very important to learn proper technique and to do it faithfully every month.
Well, I hope, if nothing else, our audience walks away with that, the importance of
breast self-exam.
I mean, is it possible for you to discuss how this is done?
Absolutely.
I mean, without a visual aid right now, but...
Yeah. Actually, if you're still menstruating, the best time to do this is about a week after your period, okay? Because right before your period, your breasts tend to swell and you tend to get more cysts. Usually we start out by undressing and looking in the mirror. And if you can just raise your arms up like this, you can just look at the contour of your breast and see if anything is unusual. And as time goes on, you learn to know what your breast looks like. And if there's something abnormal, you're going to be the first person to pick it up. If there's any dimpling in your breast, if your nipples have any dimpling, if your nipples have any discharge, these are all things that have to be brought to a physician's attention. Okay. The next thing to do is to go into a shower. And that's the easiest place to examine your breasts initially. And because it's slippery, and what you do is you take these 3 fingers and you go in a circular motion starting at about 12 o'clock, and you just go all the way around, feeling every single part of your breast. And you do about 4 or 5 circles until you get to the nipple, and then you examine the nipple also itself. After you come out of the shower, you should lie down on the bed, put your head, your arm above your head, so that you can, everything is spread out. Basically, your breast is flat that way. And do the exact same process again. Okay, so this way you're examining your breast in different positions, so that if there's a lump that you can't feel standing up, you may feel it when your breast is flat.
Okay, once again, this is Forward and Out, and we're here with Dr. Karen Bigman. I just want to mention the clinical exam. How often should that be done?
The American Cancer Society recommends that between the ages of 20 and 40, it be done about every 3 years. I think that if you go in for your yearly PAP, it should be done. And I think that that's very important. The majority of women that come into my office have found the lump themselves. Doctors rarely find lumps. And it's not because we're not taught how to do it, it's just we don't know women's breasts. That's why you have to know your own roadmap. And you'll be the first to pick it up in the majority of cases. Ignoring it is probably the worst thing that you can do. If you have any question, you have to go and see a physician. My theory is that if you have anything suspicious, any mass that doesn't go away with the next period, it's to be biopsied. I don't sit and wait for things to to happen or to see what happens.
Well, you've actually segued beautifully into what I wanted to get to next, which is your personal protocol for dealing with patients. You suggest having a biopsy with every suspicious lesion or lump.
If you're premenopausal and you're still having periods, cysts again are very common. If somebody comes to me with a fullness or what they feel is a lump, what we usually do is we wait one cycle, okay, and see if the lump goes away. And then often we can do an ultrasound and see if that's a true cyst, which will be fluid-filled, versus a mass, which is solid. That can be seen on ultrasound. And that's a benign test. It doesn't hurt. It's nothing.
Right.
If it goes away, then I just monitor the patient because it's unlikely to be malignant. Malignancies tend to be firm and hard in masses. If it doesn't go away, it comes out, as far as I'm concerned. Biopsy, because you would never want to miss a breast cancer.
Now, I mean, the worst case scenario is you biopsy and it turns out to be a malignancy. What happens at that point?
Well, it depends. It depends on the size of the lump, on the size of the woman's breast. The decision basically here is whether to have a mastectomy or a lumpectomy. Usually after the biopsy, they find out it's malignant, then you can go in for a lumpectomy if you have a reasonable sized breast and the lumpectomy is not going to be too deforming. There are certain types of breast cancer that are absolutely, you absolutely have to have a mastectomy. But the majority of them in this day and age can probably be handled with just a lumpectomy and radiation.
That's
and the results are completely equivalent. Okay, so most women don't lose their breast from breast cancer.
Now, when you say lumpectomy, you're saying that minimal breast tissue is removed, but
all they do is take out that lump.
None of the lymph nodes or anything.
Okay. I always recommend a lymph node dissection.
Okay.
And the more lymph nodes that can be obtained by the surgeon is better. And we don't take out the lymph nodes to cure the patient. It's really for prognosis. It will guide me as to what kind of therapy you need. If you have a lot of lymph nodes positive, you're going to need more aggressive therapy.
Right.
Whereas if you have none positive, then I can give you therapy that maybe you won't lose your hair. And
exactly.
It's a little bit easier. If you have a tremendous amount of lymph nodes and really a bone marrow transplant and real aggressive therapies have to be considered, especially if you're young.
Right. Now, I mean, I'm getting a little bit nervous about the time here, and I do want to make mention of the fact, or I want you to make mention of the fact, that women in general, but lesbians specifically, cannot be lax about self-examinations. I mean, there's a tendency, there's a kind of a thinking, women obviously don't like to go to the gynecologist. It's every woman's dreaded visit. I mean, no one likes to do this. But just keeping on top of that sort of thing, not procrastinating, not being lax.
Well, I mean, I think that's pretty universal. I mean, a lot of women are like that, just in general, whether they're gay or straight. They're basically, denial is a wonderful, wonderful thing. And a lot of people just don't want to know if there's anything wrong with them.
Have there been any studies done on evidence in the gay community, the lesbian community?
Very, very few. It's a community that's really been underrepresented, as women have basically in general.
Right.
But women, lesbians are definitely at an increased risk for having breast cancer because they don't, at least 70% of them do not have children. And that's one of the risks for breast cancer,
right,
as it is for some other malignancies also. And they're at a good risk. And actually there have been some studies published that they may be at a risk of about 3 times the national average for breast cancer.
Really? That high?
So, yeah. So it's actually more important if you haven't had children or if you had your first child after the age of 30, to really keep on top of things.
Right.
The combination between breast self-exam, clinical exams, and mammography between those three things, we can pick up a lot of early cancers.
Yeah, I just want to get this point in before we have to close the show, but the constant ovulation and no break in between women who don't have children or who have children later in life. There is no break in that cycle, and that's something that's also that's come up recently, where not getting a break in estrogen levels sometimes increases risks with these things.
I mean, basically, breast cancer is really due to the fact that besides hereditary and these other environmental effects, it's constant estrogen stimulation to your breast tissue.
Right.
So that women who've been pregnant or who have breastfed have had that break. However, there's other ways of also decreasing the amount of ovulation. Exercise is one of them, especially in your teenage years when your breasts are forming.
Right.
And it doesn't have to be a lot. 3 to 4 hours of vigorous exercise a week will decrease your incidence of breast cancer by 50%.
That's very interesting.
In young girls.
Right.
But even in 30 to 40 range, exercise will absolutely decrease your risk, because you're going to decrease the amount of time you ovulate.
Exactly.
And that's going to decrease the amount of estrogen exposed to your breast.
Right.
So it's very important, but that really is the basis of it. And anything you can do to interrupt that estrogen stimulation to your breast is going to decrease your risk.
Right.
And vice versa, the more estrogen exposure you get, whether it be through hormone replacement, especially the early oral contraceptive pills, which had a lot of estrogen in them,
right.
And continuous ovulation, especially for 40 years or more, is a big risk factor in increasing your incidence of breast cancer. Early menarche, meaning early onset of periods,
right.
late menopause, that's going to increase your risk of breast cancer, because you're getting a ton of estrogen throughout your body, and that's being exposed to your breast tissue.
Well, unfortunately, we are out of time, and I wish you could sit here for another hour and a half and go over this. I'd like to thank you for being on our show, and I hope you'll come back and inform us about the various other kinds of cancers. I mean, we did sort of focus on the breast cancer right now, and I think it's important to get the information out.
It's very, very important.
Well, again, thank you for being with us today.
You're welcome.
And thank you for being with us as well. Until next time, on Forward and Out, stay proud.
Your local Gay and Lesbian Community Services Center is a place to connect and get involved. Various ongoing groups and social events are conducted at or by your center, and it is also a clearinghouse of gay and lesbian information nation and worldwide. We urge you to join, get involved, and support your community. If you need information about HIV and AIDS, ARCS, AIDS-related community services, offers counseling, support groups, referrals, educational forums, and much more. Call the ARCS AIDS line at 914-992-1442. ARCS is here to help.